Ciao mondo, hello world, hola mundo, hello monde, konnichiwa, ni hao. The reason why I'm saying hello in so many languages is that in a few weeks from now in Long Beach, United States, there will be the annual dialysis conference, which is more and more an international venue for specialists in nephrology and dialysis from all over the world. This year I've been asked to identify specific topics that are of interest for the annual dialysis conference where I could somehow make a comment about, and the first is about sorbents. I think importantly, very much sorbents are occupying one of the most interesting space in the area of investigation in nephrology because of the idea of water-sparing dialysis techniques, but also the possibility of application of sorbents in sepsis, in acute kidney injury, and possibly also to remove substances like endotoxin and other. I think that the research in sorbents will be one of the mainstay of the future months and years research in nephrology. The second point is what about the future of nephrology and the future of dialysis? Specifically talking about dialysis technology, I think that the future will be mostly interested in miniaturizing components of dialysis. We have already presented in the past our miniaturized dialysis machine for neonates, which is basically a result of combining several different sciences, including microfluidics, nanotechnology, and others, to create a machine which is not simply a miniature of the standard dialysis machine, but it is something that has been specifically designed for the neonate, which is not a small adult, as it has been clarified several times. So miniaturization will also be important for portability, and finally probably for wearability, and if we're not dreaming too much, probably implantability. The final topic which I think is important is fluid management. Fluid management both in chronic dialysis and acute dialysis. In chronic dialysis, because in 4 hours we need to optimize the fluid status of patients that have been accumulating fluid in 40 to 72 hours before in the interdialytic period. For this reason, I think that bioimpedance methods will be more and more used, and also we are looking into new devices that provide software and algorithms that help to interpret the data. They may be called hemodynamic navigators, where basically the intravascular refilling, the fluid status of the patient, the rate of ultrafiltration are guided and driven by signals coming from the patient during treatment. But the same is true in the acute patient. Although we do normally dialyze this patient for 24 hours with continuous renal replacement therapy, the information about the fluid status of the patient and intravascular refilling is quintessential to perform a very adequate dialysis treatment and an accurate assessment of the fluid status of the patient will also provide the physiological target for the rate of ultrafiltration and the amount of ultrafiltration. In the recent DOREMIFA study, we have clarified that patients in the ICU often are fluid overloaded, and it doesn't matter whether it is 1, 2 or 3% or more of the body weight, the amount of fluid overload, this correlates with bad outcome and mortality. So optimization of fluid status in chronic and acute patients will be one of the mainstay of research in the future months and years. With this, I thank you very much for following me in this analysis, and I invite all of you to the annual dialysis conference in Long Beach that will be in March this year, and you will have the possibility to follow several of the different presentations in this field of research. Thank you very much and enjoy the cappuccino.